Muy buenos días a todas las personas que nos acompañan el día de hoy.
Good morning, all of you joining us this morning.
Unos
We
minuticos
will
para que
wait
terminen de acceder a algunas de las
one
cosas
more
que
minute
están
to let
en la
some of the
lista de
people
espera.
join the
Mientras
room
tanto, invitamos a
or the
que se
session.
sientan cómodos,
In the
que prendan
meantime,
sus cámaras y que
those that
vean
would
el
like to turn
mensaje
your
que está
cameras
colocado
on, the
en el
idea
espacio
is
en el
to
espacio de diálogo.
have a
Así que
conversation, a
felices de
dialogue today.
participar
So
y puedan
happy for those of you
prender
who
sus
like to
cámaras, prendemos
turn
cámaras
your
nuevamente.
cameras on. We understand
Estamos
that
teniendo
some
problemas
people
de conectividad.
might have
Personas extranjeras
connection
sabemos que el
issues.
internet en Chile no es
Internet
de
in
todo Chile.
Chile has not full
Entonces
coverage,
probablemente tenemos
so
que cambiar
probably
minutos en
some
las clases para
people
poder estar aquí
even had to move to some
acompañándonos y
other
entonces
place to
terminar
join the
nuevamente
session.
esta
And
comunicación.
probably that's why
No es suficiente
their cameras
para
are
poder
on because the
conectarse
bandwidth is not
de
enough.
manera bidireccional. Entonces, si alguno se
So
siente más cómodo prendiendo su cámara,
if you feel more comfortable having your cameras on, we're happy to see you.
sí, los
And
esperamos. Así
we
que desde la
hope that
coordinación médica nos
from
informen que
My
estamos
Care
listos
Coordination let us know that we are
para dar
ready to
inicio a este evento.
start our webinar today.
Está el chat abierto
The chat pod is open,
y vamos a estar
and
acompañando
of course, we
para
will
que
be
pasando.
reading this chat
Bueno,
pod.
Aranza, bienvenida. Estás
Well,
desde San
welcome,
Esteban, Los Andes, región de Valparaíso. Fantástico.
Esteban from Los Andes, Constanza.
Felices
Welcome.
si nos cuentan dónde están. Seguro
Let
que
us know
alguna vez
where you are.
aquí en Chile.
Probably it's somebody connected to the one single
Bien,
antenna that might be available.
tenemos
Anyways,
una cantidad de personas
we
importante.
have a important number of
Entonces,
people.
si no se puede habilitar la cámara, dice que
Yeah,
no.
we cannot turn
Vamos a
the
asegurarnos que
camera on.
funcione de esa manera. Bueno, pero aquí estamos. Nos vamos a estar
Okay, we will be
acompañando.
here with you
Esperamos que la
today.
próxima vez
Promise
la
you the
cámara
next
sea
time
de que
we will
prenda.
have the alternative for you to
Les
turn your
damos
cameras on.
la bienvenida
Welcome,
a esta
welcome
sesión
everyone to
organizada
this
desde el
webinar
Instituto Milenio para Investigaciones
organized
Sociales y
by
Sanitarias.
My
A
Care.
quienes nos acompañan el
Those
día
of
de
you
hoy, les solicitamos el uso
joining us today, please choose the
sea
language in which
desglosar
you wish to
las cámaras.
listen the
Hay un icono en el
presentation. There is
fondo
a
del mundo
world
de
icon
Zoom
at the bottom
y a
of
través
your
de ese
screen,
icono pueden
and
escoger
through that
escuchar
you
en
can
español o
choose
escuchar
either English
en
or
hacemos
Spanish. We have
traducción
simultaneous
simultánea al inglés y
interpretation
por favor
services. We'll ask
mantengan sus micrófonos
to keep
silenciados en lugar
your
de dar
mics
explicaciones
muted
a fin
during the
de que no
presentations
interfiramos
so as
la
not to
actividad que van a hacer los
interrupt
speakers el
the
día de hoy.
speakers
Mi
today.
nombre es Marcela
I'm
Tenorio,
Marcela
soy
Tenorio.
profesora
I'm
asociada
a
del programa
associate
doctoral
professor of
en la Escuela de
the
Psicología de
School
la
of
Universidad de San
Psychology,
Sebastián
Universidad
de
de
Los
Los
Andes
Andes,
y soy la directora
and alternate
de My Care.
director of
Desde el
My
año
Care. Since
2021, con el
2021,
apoyo
with
de
the
la
support of
Iniciativa
the
Científica Milenio,
Millennium Science Initiative of the
Investigaciones
Chilean
Sociales
National
de
Research and
Chile
Development Agency,
se dedica a
My
generar
Care
conocimiento
has been
científico
generating scientific
sobre
knowledge on
cuidado
both
tanto formal como
formal
informal
and informal
de
care
personas mayores
of
y de personas con discapacidad
dependent
gracias
elderly people and people with
a
intellectual
sus
and developmental
trabajos
disabilities. The approach encompasses a
orientados a la
characterization of
perspectiva integral
caregiving from a
así
holistic
como
perspective,
también
as well as the
de
design
intervenciones
of
basadas basadas en evidencia.
evidence-based
Para
interventions.
ello,
To
realizamos
this
actividades
end, we
inclusivas
conduct
que
inclusive
integran
research,
activamente la visión
which
de quienes
actively
cuidan
incorporates the
la
vision
voz
of caregivers, elderly people with
se puede ver
dependency,
la
and people
experiencia de las personas
with
con discapacidad auditiva
intellectual and developmental
Nuestros
disabilities.
voceros no están presentes
Uh,
porque
uh,
están trabajando,
Spokespersons are not here today
están
because they are
ocupados en sus días
working
de trabajo regular.
every
Por eso, en
morning,
algunas
and
ocasiones
that's
pueden
why
estar presentes presencialmente.
sometimes we cannot attend our
Asimismo, promovemos un tipo de
activities. We also promote a
interdisciplinaridad basada en
transdisciplinary and a
evidencia que
rights-based
reconozca el
approach
papel crucial
that
de los
recognizes the crucial
discapacientes
role of the
en el
use of
apoyo a la
technology as a
diversidad.
supportive tool in the
Desde
practice
esta
of care.
perspectiva,
From this perspective, My Care seeks to provide rigorous evidence to inform the development of public policies that address the needs and priorities of both caregivers and those who require care or accompaniment in Chile. Today's webinar is Care Interventions for the well-being of people with intellectual and developmental disabilities. Panelists in charge of the presentations today are Paulina Arango, Associate Professor of the School of Psychology of Universidad de los Andes, and Associate Researcher of the MyCare Millennium Institute. Angela Hasiadis, a Professor of Psychiatry and Intellectual Disabilities in the Division of Psychiatry at the University College of London, and an honorary consultant psychiatrist at Camden Intellectual Disabilities Service London in the UK. Angela is also a senior researcher at MyCare and a beloved friend for us. Megan Burke, professor in the Department of Special Education at Peabody College, Vanderbilt University in the United States, who we have been lucky enough to have here in Chile. And not too long ago, we met in Chicago. I'd like to thank you for joining us today. If you have questions for the speakers, you can write them now in the Q&A section or in the chat pod. And at the end of the presentations, my role will be taking these questions and promote an open discussion. We will begin then with Paulina Arango's presentation, interventions focused on the development of adaptive behaviors and social participation in people with intellectual disabilities in Chile. Thank you, Paulina.
Perdón un segundo, comparto la presentación. Perfecto, bueno, muchas gracias.
Okay. Thank you, Marcela. As you know, this is interventions focused on the development of adaptive behaviors and social participation in people with intellectual disabilities in Chile. The idea behind is sharing with you some of the interventions we've been working on with these team. Let me say that projects funding these work is coming from different sources, both public and private, particularly Fondesit and Millennial, which is Ministry of Science, Universidad de los Andes, where we are now, and Fundación Isabel Aninat. To be able to focus on the topic today, interventions, let me offer context to explain the reason of our interest in the development and the work on these interventions. People with intellectual disabilities, particularly those with we know that they live in a social exclusion situation. And this is particularly important when we work with these population within different contexts. Exclusion is not only true in school or at work, but overall in social engagement, and means that this is a priority area for intervention when working with this population. And for that, to that end, we need interventions based on evidence that may facilitate and promote social engagement of people with intellectual disabilities. And for that, we know that we need the interventions that will encompass multiple players, especially us from psychology and from healthcare, we believe interventions are something that is focused on providing skills or changing something in the person, him or herself. But what evidence has shown is that the effective interventions are those considering the person, the individual, and the context and the engagement, the interaction between both. So let me share with you how we address this in multiple programs. This interaction between the individual and the context, and something that is important for us working in this part of the world is that even though there is wide development, I mean, not as wide as we would like to, but there's lots of work in interventions and programs focused on working with these populations. But most these work come from cultures which are different to ours, contexts which are different to ours. So means that we do not really know whether those interventions will be adequate or context or not. Therefore, we need or a little has been done on psychological and psychosocial interventions from Latin America, particularly in countries with low and medium income. But Latin America, which is the context we live in. So, and that therefore led us to work on this topic and to combine in the research team basic and apply research so that from the basic research we can make decisions as to what is or where should we focus on such interventions so as to have a practical application. Specifically, I will be discussing three programs, three intervention programs we worked with the Universidad de los Andes and my care. And this intervention, this presentation has a perspective of a life cycle. So baby my care first, which is focused on working with Down syndrome baby families, then one on teenagers, and then third intervention covering the whole life cycle, which is a bit wider. So let's start with baby my care. This is for families with the Down syndrome babies, for families. This is an intervention aiming at first, families can know and understand the development of boys and girls with the Down syndrome, with focus on that population because of the target group, the age group of babies, where of those families, which is a group where through the intellectual disability identification process. So we model that with the Down syndrome, but we understand that this may be adapted to other populations. So first and foremost, families should learn and understand the development path of their boys and girls, understanding that when we have a condition that which is a risk factor for atypical development for intellectual disability, we need to understand what happens with that such development in order to achieve the two other goals, which is knowing and understanding the skills that will promote interactions of caregivers, parents with their boys and girls with the Down syndrome, which of course has to do with their development path, and the caregivers can have practical skills to promote such interactions. So why these interactions? Because we have lots of evidence that's showing that those interactions, early interventions, will be the foundations for the cognitive and adaptive development of children, of kids. That's why we promote tools and skills with experience promoting development. Therefore, our hypothesis is that by developing these skills will promote development and therefore participation of children.
This is a program that is subject to a manual that is made up of 10 sessions. We'll have 2 sessions that are face-to-face as a group, and the other 8 sessions are individual sessions. Uh, a therapist with a family. The testing was done with an online delivery, but that might imply a face-to-face intervention. We did it online because the context we're in, and especially considering that these are families with babies and small children, many times a barrier to becoming engaged in interventions of this kind is precisely having to move, taking the time, etc. So that is why we thought of it like that. Each intervention takes 30 to 45 minutes, depending on how the session goes with each family. And we mainly focus through video feedback on material that we give the families and in the interaction during the session itself between the therapist, the caregiver, and the boy or girl. Uh, with these 3 inputs, we work on the different skills that are considered in the program. And also, besides what happens during the session itself, the family receives information, feedback or material or a pre-reading material. And at the end of the session, they're also given more material with a summary of the session itself, and we provide them with some tips and strategies as a reminder of the session itself so they can continue to implement those strategies in between sessions. What do we work on? We work on specifically on sensitivity and non-directivity. Sensitivity is the ability or the skill of identifying what the boy or girl may need and being able to respond to those cues. So when they are babies and they cannot express verbally what they want, it is very important to develop that skill of caregivers of realizing, of being sensible enough when a baby has a certain behavior, maybe thinking of what is the reason for that behavior and being able to respond to that. That is the first approach. And the second one is non-directivity, which means how can we guide the activities of that boy or girl without being intrusive and without exerting pressure? How we guide the activities of the boy or girl, that's something that we do every day, adapting to the skills, wishes, interests, and needs of a boy or a girl. Basically, it's about how do we motivate them to conduct their lives every day. So these sessions include half of the program focused on working on sensitivity, and the other half of the work is focused on the non-directivity approach. And we close with a session in which we work on specific aspects of the interaction itself, which has to do with reciprocity between the caregiver and the child. Each one of them answers certain questions about what the other is doing in order to favor that interaction. Something important besides the intervention itself is that first we work on skills with caregivers, developing play activities, and then we transfer that to daily lives activities because what we need is for parents or caregivers to be able to use these activities in their everyday lives. I'm going to, after that general definition about the program itself, let me show you now the research itself and the evidence that we have. This is a program that we have already implemented. Uh, and the method that I'm going to show, but we are doing the last assessment, so I can not show you yet the stability in the long run of this change. We had a sample of 40 families of boys and girls with Down syndrome. The baby and one of the caregivers take part, which can be expected in this kind of interventions. And in many cases, it's the moms that are the caregivers. But we also have the engagement of some of the fathers. We have an ethical control design. That means that we have an experimental group that was subject to the intervention, and we had a control group as well. And once we once we ended the intervention with experimental group, we offered the control group families whether they wanted or not to receive the intervention, and that's something that ended recently. And as to the variables that we assessed, the interaction first. We expect this intervention to favor children's development, and in order to do that, we use TADI as an instrument and also the MACI. TADA is a development scale, and the MACI is an instrument to evaluate the intervention itself, where we evaluate some parents' skills, sensitivity, and non-directivity, which is the focus of the intervention. But we also assess other variables, such as, for example, attention to the caregiver, how much they express negative or positive affection, and how lively they are, and how active the boy or girl is during the interactions. And we also assess certain variables regarding the interaction itself, which has to do with how mutual the activity is, how much do they share the activity, and how they share the emotion involved during the interaction. The intervention focused then on modifying sensitivity and non-directivity of the caregivers, and we hope that this will have an impact on reciprocity and the fact that both parties are engaged in also the developmental variables. As to the research method, this is the typical design. We did a pre-intervention assessment of all these variables. Then we actually conducted the intervention in the experimental group. We did a post-assessment to check for changes, and then we conducted the intervention in the control group. And as I said, we are right now, as we speak, completing the follow-up assessments that are done 3 months after, uh, uh, excuse me, 6 months after the completion of the intervention, to see whether changes did happen and to see whether those changes are sustainable in time. As to the feasibility of the intervention, which is an evidence that we collected initially to know whether the intervention is something that the families receive with a positive attitude and that they feel that they can be engaged. We collect information about attendance. It was 100% attendance to the interventions. There was no attrition. No family dropped out of the process. 0% attrition. So that's something those of us doing research in this field is very difficult to achieve that level, and therapists played a significant role in that. In order to achieve that, what did happen, though, with many families, is that from the beginning, we established a set time and day in the week when the sessions were going to take place, but in 70% of the sessions had to be rescheduled because of several reasons, because the children were sick, because of an emergency, because they forgot, or there were some connectivity problems, etc. But the good news is that in spite of that rescheduling, because we needed to be very flexible, of course, we actually kept those families connected and motivated. We also assessed how faithful therapists were in following the intervention itself. When there's an intervention that is part of a manual, there are objectives and activities that are scheduled for each session. And so we measured how much they abided by that initial plan. And in this case, it was 97% of the sessions they followed that plan as stated in the manual. And when it wasn't followed, it was because of very peculiar situations, either because, for example, in integration sessions, that's when we conduct uh, uh, activities of transferring the skills we develop to their daily lives. We choose an activity because we choose that together with the family. We chose an activity maybe in which children had additional sensory difficulty, so the activity had to be changed, and therefore the session did not take place as scheduled originally. But those were very, very specific situations, and that means also that for therapists, it's easy. It's easy to follow the manual and to follow the plan. And we achieved a satisfaction with the families. So the maximum score was 35, and the average satisfaction score was 34.53. So that speaks of the fact that how accepting the families are and how useful the program was for them. As to the effects of the intervention, well, this table is a bit busy, so I will try to explain the main aspects of the results. So something important here is that we compare the control group and the intervened group, and that's how we measure whether the intervention was effective or not. The skills or the variables change in the intervention group and not in the control group, or at least not in the same way. And in most of the variables of the interaction, that was what we found. So what was really important is that we found that families in the intervention group changed, modified their response. They were able to be more sensitive and less directive. So that was a change in those skills in those parents that received the intervention. And also that it would seem this is something that we need to still delve deeper into. But if you see, there's a change in the case of the positive affection in babies. Babies that were involved in the intervention did show uh, more a better expression of positive affection during the intervention that was assessed, and also how mutual the effort was, which has to do with reciprocity and taking turns for the activities and sharing in the interaction. It also experienced a positive change. However, and also engagement, intensity in the engagement. We Those were the changes and the variables that we expected to have, and also in this first part, there's something interesting. Is that we compared whether the effect of the intervention was the same in the families at the beginning, that at the beginning were more sensitive and less directive, or if the intervention did have a different effect depending on the initial skills of the parents. And what we found is, in fact, there's a difference in the effect. So of course, we'll see a larger change in those parents that had lower scores at the initial assessment, which is also important because those were parents that or caregivers that possibly do need a more intense intervention. So that makes us quite happy.
Okay, this is the first part of my presentation. This is another project called Towards Autonomy, where we have an intervention or encourage adaptive behaviors based on games and for teenagers with Down syndrome. These are 13 1 hour and a half sessions once a week. In a small group, they would come to the university. We had some group activities and some activities where this big group, 20 teenagers, were broken down into smaller groups. And we worked with families because, as I said, it's important to work on context so that's to reinforce the skills we'll be working at home. And we did this intervention so as to make it as ecological as possible, meaning through day-to-day activities, we taught the various skills we wanted to work on, focused on self-direction, functional academic skills, social skills, communication, the use of community resources, which are skills which are part of the adaptive behaviors with people with intellectual disabilities, which will be the core of their social engagement and autonomy. I briefly will discuss examples of some of the activities. If I mean, we can always share with you additional information because that's it's otherwise we will take too long. So we had activities where we uh, teenagers would organize a party or and or cook. So and these activities we worked on planning, decision making. They to organize a party. They had to work on the budget, what to buy, priorities, because they have a given amount of money they could use. So, and as a group, they had to agree on what to buy, and then they went to buy the things. And of course, we had the party. We had activities of moving around the university campus and then around the city, planning how to move, how to go from A to B, use of maps, the use of Google Maps, the use of public transportation,
También de habilidades.
social activities, communication skills, social interaction. And through these activities, then we worked on these adaptive skills. We had 40 teenagers with Down syndrome between 13 and 17 years of age. Same design, or first a control group, and then an intervention group, and then the control group was also offered to be part of the activity. And so our target variable was changing the adaptive behavior. Then we used ABAS2, which is a survey for parents and teachers, where they tell us, they let us know how these adaptive behaviors are doing. And as far as the results, we had very interesting results and several skills. More importantly, the use of community resources, which has to do with using public transportation, knowing where to go, if you want to buy something, that type of things. But also, we found effects, positive effects on other adaptive behaviors, where we found big changes in variables, except for self-care. That has to do with conducting activities to promote my health, hygiene, that type of activities. And this is this is a skill which was not which we did not address explicitly. As you could see, this was not focused on it. And I mean, we we did not expect a big change here. And last but not least, cuidados. This is a training for caregivers for intellectual disability people. And here we have a different program. This is we only work with caregivers. The goal is that with this change in behavior of caregivers, we can promote participation and life quality of people with intellectual disabilities. And we're thinking here of families and caregivers helping people with intellectual disability at any age. For this program, then, this is a training program. It's a 64-hour program. It's quite long. May be implemented in 8-hour sessions or 16 4-hour sessions, which is a very extensive, very long program because we work on several elements dealing with care. We're thinking of people helping people with intellectual disabilities and requiring lots of support, both behavior and assistance. So we offer them lots of care tools, how to manage medicines. But we work quite strongly on training them from the perspective of rights to understand what's intellectual disability, uh, working on promoting autonomy, and we end up with benefits from the government here in Chile for these families to apply. And we have a fifth module here, which is self-care, which will be key for these caregivers, particularly we think these are people helping those that require lots of support and assistance. So that means the process is long because we work on self-care as a content. And since we want to offer practical tools, we have the caregiver box, which is actually a box, a physical box, and lots of material designed for the program, which we share with the attendants, things like alternative augmentative communication tool. The idea is to work with the person they help, they support. This is an information on the benefits from the government. Um, this is this is some sort of a logbook for medicines. So this is adapted and tailored to the needs. In this program, we had 80 people, 95% women. No surprises there. I mean, most caregivers are women, and from all socioeconomic levels, low and medium level, mostly. I mean,
Probablemente tiene menos
population at
posibilidades de
least
recibir
possibility
de apoyos y
support,
que, como les decía, acompañan a
as I
personas
said,
de todo el rango de edad. Y
individual
hemos tenido además la
ages
mitad de cuidadores formales, que son cuidadores
or
que trabajan sobre
formal
todo en instituciones,
caregivers who
y
work
la
with
otra mitad
institutions
de cuidadores que llamamos
have
informales,
is informal caregivers, relatives, mom, an aunt, a sister that will do the accompaniment. As to viability and feasibility evidence, that's the average attendance was 80.5% and only 6.9% attrition, um, uh, which is which is a very good number, especially thinking of such a long intervention. And satisfaction assessment, the average was 4.85 out of 5. As to specific impact, we measured the knowledge on rights, assistant care, and support, and stimulation for all those that help for their autonomy and social engagement. And there we see a big change where caregivers were not aware, for instance, of the rights of people with intellectual disabilities and what to do in case of breach of violation of these rights. And they would now report that they know what to do in this type of situations. And also attitudes and beliefs as to mean care, providing support to people with intellectual disabilities, how trained they feel, and also as to the importance of self-care. I mean, to be good, and the impact it has on this support work they carry out. And last but not least, life quality of people with intellectual disabilities, which of course we need, we want to change the life of people with intellectual disabilities. We found changes. Was quite a surprise because in a short while we were able to see changes in self-determination, rights, social inclusion, and personal individual development. There are some other elements where we found no change, but we are in the process of collecting this follow-up information because probably these things may take a bit longer surfacing. Okay, and now in closing, as I said, we need more evidence-based programs to carry out this type of research work. It's not an easy thing. It's very expensive. It takes long, but it is important. Families, caregivers, teenagers, people with intellectual disability, they acknowledge this, how important this is. They are grateful because we know this is necessary. So it's important to continue to work on these development, and especially for those from other countries in Latin America. We always Angela and Megan, they know about this. I mean, look here. We are doing interesting things, quality things that may be of a contribution to what you are doing in other parts of the world. We are willing to bring things from abroad. Ideally, we could contribute to other places also. So you are all invited to learn what we do. And let me thank in closing. I'd like to thank this team. But some very important, Marcela talked about our my care spokespersons, Florencia, who's the leader. I mean, they're always working in the decision making, and our great research team. Without them, none of this would be possible. So, of course, you're welcome to learn about my care, and this is the end of my presentation. Thank you. Thank you, Paulina, for the presentation. And now I leave you with Angela Hasiotis on services for people with intellectual disabilities and mental health conditions. Angela from London, thank you for being with us. And the floor is yours.
Thank you very much, the Mikare team, for giving us this platform to hold the webinar today, and also our interpreters for doing such a difficult job to making sure that we can understand in both languages. And it is really, quite a global perspective, and I agree, in fact, with Paulina's kind of last comment in terms of contributing to the knowledge and practice that you could offer to us, and also, how we may be able to help you to take things forward. And it's very interesting to me always to hear about trials are really very difficult to do, no matter where you are in the world, and to see that, for example, you know, I would be interested in finding out a bit more about how do you keep your attrition rate so low, or, you know, the fact that we do share that, you know, you have to reschedule appointments because, of course, these are very busy families with lots of appointments and lots of needs. So really, you know, these are kind of commonalities that we can definitely learn from each other. Okay, so let's see. So these are just my conflicts of interest. Well, I hope there's none. And I'm speaking as a practitioner in intellectual disabilities, but not on behalf of any particular organization. So I'm going to talk about some general principles today, some cultural perspectives, which I think are very important, especially because in every part of the world, there isn't just a single population group from a particular background that we deal with, but we actually have to be much more aware of, you know, people who may not share a cultural heritage, and we need to be capable and sensitive to their capable in order to be able to manage their needs and respond to their needs, and also sensitive to the things that they bring to us, so that we can support them to improve their lives. I'm going to talk about service structure, and I will give a little bit, you know, some information about what we know is happening in other parts of the world. And I come from a particular perspective because in the UK, we've got a specialty in intellectual disabilities. So it's one of the psychiatric specialties. And in some respects, perhaps we are privileged to have this, but I am also very aware of really very positive work that happens elsewhere, even without having a particular specialty. So people do develop interests, and you know, we've got also colleagues who have come here to you know, increase, I suppose, the sort of knowledge and awareness, I guess, about how they might be able to do things differently. And then I think the questions and answers will be at the end of all three presentations. So the objectives for my presentation will be really to think about the principles of service provision for people with intellectual disabilities. I thought it is important to kind of put this in, because I'm not sure who exactly is in the audience and what their background, but I am aware that there are colleagues from other parts of the world who have expressed an interest in sort of finding out more about intellectual disabilities. And if there are any colleagues in training or working as independent practitioners, that might be something they want to take out of this presentation today. So I hope that you will be a bit more aware of the challenges in service provision in low and middle income countries, and where there is no specific specialism, thinking more about the cultural aspects of health in people with intellectual disabilities, and also some ways in which knowledge mobilization may take place across countries. You know, with those points in mind, I'm just going to go into some the general principles, really. And we do talk about fairness and impartiality and equality. But I think sometimes perhaps we say those things, but we may not necessarily practice them. So we don't walk the walk, as it were. And even if we do, there may still be elements of stigmatization or elements of exclusion and so on. We talk quite a lot now about reasonable adjustments. In fact, this, at least in the UK, starts from the point of identifying who has an intellectual disability, regardless of the setting in which they find themselves. So, for example, it could be within primary care. In the UK, primary care services are being incentivized to do exactly that, actually assess who in their caseload will have an intellectual disability, so that they can provide better care to this population group. When people go to a secondary hospital, so for example, if they need emergency care or they need a particular specialty, whether it's general medicine, for instance, surgery, neurology, whatever that is. Usually that is being offered within a hospital setting. And it's, again, it's important that they, the hospitals are aware that there is someone with intellectual disability in the waiting room or meeting a consultant or another professional. So the reasonable adjustments, for example, may be that there is another person in the room with the person with intellectual disability. It would be that we provide easy read information so they can understand what it is that we are telling them and how we explain particular health procedures. It could be that we provide a double appointment. So it's not going to be the 7 minutes, for example, that usually apparently general practitioners in the UK offer, but it would be, 15 minutes, for instance, for someone who's got an intellectual disability and so on and so forth. Or if there is a hidden disability, for example, someone who may have some sensory impairment, or they have they're very stimulated, say in a when they are with lots of other people, etc., to try and offer an appointment at the time that's more suitable for them. We also had the Equality Act in 2010, so obviously we have to provide as much as equal care as is possible, with including all of those things. We try to be personalized. Now, personalization has lots of different meanings depending on which branch of medicine one is speaking of. But within, say, the context of social care, that might be, getting goals to that are relevant to the person with intellectual disability and their families, or be very specific to the offer that one makes, to the needs that the person brings to the professionals and the services and so on. And of course, we always have to think about the person being at the center of everything that we do. We try to co-produce services and research, and actually co-production would be even as perhaps a simple act as putting a plan together about how we are going to help the individual, and actually try to listen to what they're saying. And that would be, for example, conversation about, say, medication and what they want to have, or when might be the better time for them to take it, or what help do they need in order to take the medication, and so on and so forth. And we've got to be very, very aware, and I have to say this time and again, that diagnostic overshadowing is still happening. And I actually found out from some colleagues in the United States that the National Institute for Health in the United States have paid a significant amount of, as a grant award, to actually look at diagnostic overshadowing in people with disabilities. So it has not by any way gone away. It's still a problem, and we need to address it. For anyone who is not very familiar with the concept, basically that means that we attribute everything to the intellectual disability, or disability of any kind for that matter, and we do not really look at the underlying issues with really dire consequences, for example, which might be from the most serious early mortality, to obviously impaired quality of life, exclusion, and over medication, restrictive practices, and all of those elements. So we really need to be very, very aware. Mental illness that has not been assessed, diagnosed, and treated. So all of those things actually are still quite prevalent. So thinking a little bit about the cultural elements, and in terms of access to healthcare, particularly in modern societies, and where we've got ongoing population changes, and immigrant populations, for example, joining native populations and so on. So these are all groups of individuals who are actually often underrepresented in health services. And there could be also populations with low health literacy. Now, we've said this so many times about people with intellectual disabilities, it's beyond doubt that they do have low health literacy, and they are not going to be motivated sufficiently to ask, for support in terms of their health, even when they may be in pain or there is a kind of obvious problem. There is some information there from the international literature about how, for example, this kind of difficulty is showing or displayed in various services and for different issues in a number of countries. So say California, for example, which actually has quite a large number of Latino population. So they, the screening in Spanish is actually offered to a minority of patients and or people who attend, for screening, etc. So, and we've got Megan, I suppose, from the United States today. So she may say, well, maybe that's not the case or not. But even if it's not, say, the case where we work specifically, I think I have heard enough from a number of different countries to say that there is what we might call or at least in the UK, we call a postcode lottery. So depending on where you live, you may or may not receive certain services. Now, obviously, we cannot exclude institutional racism as well as stigmatization, and we know that research suggests that even health professionals can be can be offenders within this particular kind of context. And there is an offer, I suppose, as to what we might be able to do better with the culture formulation interview. And actually, in our trust in that's the kind of health entity, mental health entity, I should say, in Camden, where I work in inner London. We have a colleague who actually is the lead for the cultural formulation interview. And if we find that we've got a difficulty or we wish to consider sort of other perspectives and so on, we can have access to him and his team to actually help us through taking a kind of history that considers, I suppose, all of the elements that a person maybe bring to us as health clinicians. Now, I have taken this from actually a colleague, James Smith, who someone I collaborated with some years ago. He's now working in Australia. And actually, I used this case because, in fact, when I was reading about it, it's a similar case to what I could have said from, say, here in the UK. And I'm sure that many of you may be recognizing some aspects as, things that you have dealt with or has been brought as problems to your to you, or if in referrals, say in Santiago, etc. So this Joseph is a 24-year-old who lives in supported accommodation. He has mild to moderate intellectual disability. He also has autism spectrum disorder. And over time, although Joseph is only 24 years old, but actually since he's kind of going through services from childhood and teenage years, and then as a young adult, he's got different diagnoses. So, sometimes he may be seen as psychotic. Sometimes he may just be seen as having an emotional dysregulation. Possibly all of these things happen at the same time or are comorbid with all the other things that are going on in his life. And the main issue is that of behaviors of concern, where there is significant degree of aggression. And this is always, the sort of thing that's going to bring someone to our door, basically. So, however, Joseph is not just the problems that we know about him and the reasons for the referral, but he has some, he has a personality. He's the people who know him describe him as someone who loves going to the beach, for example, or he loves going on trips, and he likes kind of being in a car for all sorts of reasons. It may be even a soothing activity. And actually, despite the fact that he has a diagnosis of autism, he also has friends, or at least people that he wants to be with at a local day center. So often the situation is, so what are we going to do with Joseph? Because obviously the problems that he is bringing to us will possibly affect some of the things that he likes to do. And we often see that someone, say, has an episode of aggressive, challenging behavior, and then there is, we are going to stop the services until you do something about it, and then we're going to restart. And people's lives, in fact, can be measured almost in those stop-go situations, and where they spend some time at home, then things kind of recede, then we go back to the day center. Of course, the next time they have another episode, the same cycle kind of goes again. So you can see here what other things have been going on. So clearly, these are the sort of situations that impede the, his quality of life. And there has to be some way where we have to think, okay, what are we going to do for Joseph? And the thing is that the psychiatrist then becomes also the point of the focal point. Like, the psychiatrist has to deal with this this issue. And I suppose depending on the amount of risk that one sees or assesses in a situation, then it may be that something a bit more restrictive might be implemented, especially if the rest of the network feel that there is nothing else that they can do. And I have to tell you that I do dread this. There's no more that we can do at this point. You take over. So there could be a number of different perspectives on this. So, for example, Joseph may say, well, I need more support. Where will I get this? Or my needs are not being met. And Joseph could be also from a different background to mine. So he could be from a different ethnic group, for example, or there may be an intersectional situation which I would have to think about. I don't want to be with my support worker. And we hear this often. People actually do not necessarily have a choice as to who is going to look after them. And also sometimes life intervenes and the person who is the preferred person is not available. So we also have to think about, as I said, the person being at the center. So if we make decisions about Joseph, and if Joseph is able to speak up for himself, then that's fine. We have to include him. But if Joseph cannot, then we have to use what we call best interest and an advocate for him. And then about the medication, that we do have to think about the side effects, the kind of how does he respond to it? Is it the optimal dose? Is it the optimal actually medication? Now, the support worker may think that, okay, this is beyond what I've known Joseph behaving or behavior that displayed previously. So they think that he may have a mental illness, the issue of aggression, and the fact that the carers may not feel safe to look after him. So there is some change happening in the way that they see Joseph, or they see what they can actually do for him at that point. And then, as I said, he can't go back to the day center until he is calm. But then, of course, when you go to these different environments, there will be different triggers and different ways to modulate behavior in each of those environments that don't necessarily cross over. And we have to create efficacy in those who will look after Joseph and in Joseph himself, if that's possible, so that there can be you know, the a possibility for the person to generalize behavior in other environments. So the question that we often have as clinicians will be, what do I do next? Often, I think this is a really a very real situation. I don't want to prescribe, but then what other options do I have? And sometimes, in fact, we may have to do things concurrently. So we prescribe, but we don't forget that there are other things that we need to do. What happens with Joseph's home, for example? Is it the appropriate environment? Is there anything that can change in the way that the day center operates, for instance? What kind of other things may have contributed to the changes in his behavior? Now, the medication safety and risk. So we take our cue here from the National Institute for Health and Care Excellence guideline, which is that we should prescribe if we all perceive, it's not just a subjective, like, personal opinion. I think that it's risky and, you know, let's go and prescribe. But in fact, if overall we see that things are escalating in a way that it's not possible to support people immediately and to prevent from injuries happening and so on, we might have to prescribe. In the NICE guideline, and I was in the development group for that, we said 6 weeks and reassess. And I think, so in fact, and I speak as a clinician as well, my problem is not so much to start the medication with precisely, you know, within those parameters. The problem is then when it comes to 6 weeks and say, okay, now we need to stop and we need to see how things are going to progress. What else have we put in place? What kind of wraparound service are we offering Joseph and his carers and his family in order for everybody to be safe? And also, we have to think about the future, because this is not an isolated example. This is something that happens time and again. And I will say that I had a recent conversation with a colleague who visited us from a different country, and it was exactly this particular scenario that played out that we were talking about. And I must say that he despaired because it was, you know, sometimes it seems as if in order to put those structures together, especially when we talk about cross-national sort of borders and so on, it becomes, you know, when those structures are not available, how do you actually make them happen and happen fairly quickly? So in terms of what we are doing here, and you can take as much or, you know, as less as you wish from this, but frankly, I don't see that you could do things in any different way. And you may argue that I work in inner London and my service is really well resourced and we've got lots of people who think along similar lines. And we've all been a fairly stable team that we've been working together for some years, et cetera. But it can't happen otherwise, I will say. We've got to have, and we did hear a little bit about this, about the multidisciplinary, and I suppose we saw this in, you know, Paulina's research that's interdisciplinary and it depends on lots of people. Well, the care of people with intellectual disabilities clinically does depend on a lot of people, and it depends on all of us working together. So we've got in our service, and probably most of the services in the UK, whether it's, you know, high or low kind of ratios of different professionals, etc., doesn't really matter. But these are the sort of things, this professions that you need to have available. So you've got to have a team of psychiatrists, of psychologists, of occupational therapists, of nurses, of social workers, and we are what we call an integrated service. You can, you know, you can live or take the integration in the sense that we are both social care and health, and I suppose this is generally the model, but you know, there could be some permutations of that. But on the other hand, absolutely, you do need all of those professionals to actually do their work. And we consider that we think that the behaviors that challenge can be managed in the NHS, and we also offer social care. In fact, actually, the people with intellectual disability are first clients and registered for social care, and it is then that they will be referred to us if they've got a medical psychiatric problem, basically. We also have, and I think that's something that probably is important really to say, that there has to be some central direction on this. So I'm glad to say that we have helped in some respects with our research to contribute to those national guidelines and programs. But the STOMP, which is the over-medication, stopping the over-medication of people with a learning disability, autism, or both, and learning disability, again, for those of you who may not have heard this before, it's intellectual disabilities, but we use this in the UK, so I'm using it interchangeably. And there are also statements from our professional organizations, and I understand, of course, that professional organizations can be in all sorts of forms, again, in different countries, but you really need to look at what is possible to do at a national level. And I feel that you've got, at least in Chile, from my experience, much better kind of contact with your lawmakers, and possibly in the US as well, at least per state, if not federally, than we do in the UK. But on the other hand, I suppose somehow we managed to make our views to be kind of follow the ladder towards the high echelons of government. We've got a number of legal frameworks. So for example, we've got the Mental Health Act, which is if we need to detain people in hospital, and there is some big debate actually happening at the moment about how the revision of the Mental Health Act serves or does not serve people with intellectual disabilities, and that's some, probably for another time. We also have a national act, which is the Mental Capacity Act. There is a court of protection associated with it, and this is about how we consider capacity across the board for anyone who lacks capacity, and there is a test for it. And we don't do anything if we haven't done a mental capacity assessment. There is also, various other acts, like I mentioned, the Equality Act and the reasonable adjustments. That's really quite big, these days, as well as the Health and Social Care Act. And the Care Act is about providing support to anyone who needs it. And there are certain targets and key performance indicators associated with those. So that's really, very important. On top of that, we've got a national mortality audit. So anyone who dies with an intellectual disability goes on a separate data set, and then we kind of look at the data, etc., to see what they tell us. So for example, see what happens, in Australia, just as a way of thinking how things can be transferred elsewhere. And Australia is the same as anywhere else in the world in this respect, bar the UK. So they don't have specific services. I mean, James is actually a specialist in intellectual disabilities, but actually in Australia, he is a psychiatrist, not, a specialist in intellectual disabilities like I am. So you can see there how, for example, he describes what they do. And you can see from the change, I work for the National Health Service. They work privately, so they've got waiting lists, private fees that they have to pay, and so on and so forth. And I believe to an extent, again, I don't, I hope I'm quoting this accurately, but that was the situation I saw, happening in Chile too. But I guess people will try and do as much as is possible. And James, for example, has managed to set up on a state level, not kind of across England, say like here, but on a state level, that's New South Wales, a service that actually provides consultations to anyone who has a mental health problem or behaviors the challenge and has an intellectual disability. We must not forget as well that in people with intellectual disabilities, we talk about all of those things, and those problems, the chronic disease is actually really a scourge of the quality of life for people with intellectual disabilities: frailty, polypharmacy, physical health problems, sensory problems, mobility, epilepsy, which is great contributor not only to health inequalities but also social inequalities. Name it, all of those things will add to premature mortality. And this is a really good paper, sort of brings everything to focus. So we've got several, as you can see, several years of earlier death. And I guess the important point here is as well that the disparities are actually similar across countries. Whether you look at the United States, and there was a whole special issue dedicated to early mortality in the United States, looking at various data, etc. Whether you look at Scandinavia, whether you look at Australia and so on, the same message. So then how do people ask for help? So often people think that they're outsiders, that our services do not understand them. Now, we are probably much more familiar with Bangladeshi and Indian and Pakistani cultures because they're very prominent in the UK for many years, but perhaps there will be other countries that I don't have actually that much experience and I don't know much about them, say Burkina Faso or somewhere else, say in Africa or other parts of the world. There could be different beliefs about health. So sometimes we have to negotiate what the family think about disability and what we think about disability and how we're going to make this work for the person in the middle. They will still use some traditional healing, and we've seen this in a number of experience from my cases, and they can use, so I will prescribe medication, they will be using another healing system, and sometimes we won't know about this, but then, there is a worker, a professional who is from a similar culture, and then everything kind of gets unlocked. So we really need to be very sensitive and sort of observant for those kinds of things so that we can actually understand better what goes on with our client group. This WHO Atlas was back in 2007. I'm afraid that there has not been any new information on that. But at the time, and obviously it's out of time, maybe the 39% that used to have policies, that might have gone to 50% or whatever. But I understand that, for example, despite the fact that the whole of the world has signed up to the Convention of Human Rights and so on from the UN for people with intellectual or other disabilities, actually in practice, many fewer people or countries have anything that pertains to it than what you think they or is indicated by those signatures. And there's a lot of variation in service provision, and in terms of lack of national policies. With Marcela and Paulina a couple of years ago, we did looked at Chile, and we couldn't find anything. Well, you couldn't find anything specific relating to people with intellectual disabilities, and yet Marcel and Paulina have been working in the field of Down, with people with intellectual disabilities, Down syndrome and so on, for all of their careers. You can see some of the evidence here. We, from time to time, we actually see something in, say, one of the journals, from South Korea, or now with the pandemic, quite a number of countries kind of written up about how to support people with intellectual disabilities and COVID and so on and so forth. So maybe that's going to change as we all become a lot more aware of issues of, supporting people with disabilities, So perhaps the landscape is going to be significantly different than how it used to be. So I don't want to be negative, but I want to actually provide an optimistic message in terms of how we go forward. So, you know, there's still, however, several parts in the world that do not have enough psychiatrists, for example, or enough kind of mental health professionals. And we have to work actually in terms of increasing awareness and using the kind of interventions that will be scalable and can be delivered by people who are not, you know, post-university and post-doctoral, and they've got kind of huge number of qualifications and so on and so forth. Sometimes things can actually be preventable and they can be taken care of at a very early level. And then how do you get people, obviously, in terms of, you know, where they need to get? So if you've got an outpost, and I think actually our colleagues in Australia have been very good at this in terms of delivering more and more of their treatments, you know, using telehealth. So multi-agency and interdisciplinary perspectives, it really is very, very important. And then how do we do service development? Well, through research, so that we can go back to policy, because sometimes we have to respond with policy and then do the research to support the evidence. Practice, and of course, education, with training, with awareness, with saying the same thing time and again. And then just to show you a couple of things that are, I think, actually, although the person who's written this is Ruth Northway, who is a professor of intellectual disability nursing, but I believe they make sense kind of more nationally, and I'm happy for my slides to be shared so that you can have them as well. But you know, she's kind of, what basically she's done is to break down the kind of things that you can do. So if you look, say, at the professional practice, what will be the first thing that you can do tomorrow? And then what will be the next thing that you can do, say, in a month's time, and what you might do in a year's time. So this is how you really need to be looking at those things. It's unlikely that you will be able to do everything together. You will need to champion, to lobby, to ask people to, you know, to do certain things, to bring them to buy in, etc. But you can actually break it down, you know, the sort of various aspects in a way that can make sense in your local kind of context. And I just want to say a little bit about, very briefly, you know, some of the considerations that we need to have, like the social cultural focus, like the funding, because always, you know, we compete with other priorities. You know, how do we get the training, for example, to be available? You know, what do we do with autistic individuals, who is actually a kind of different group than people with intellectual disabilities, but with equal needs? You know, how do we conceptualize sort of, you know, what's a learning disability? Is it the same with intellectual, you know, difficulty, or and so on and so forth? So then these are kind of different perspectives that we need to know. The issues of stigma, it's still going on. Influence of, say, religion in terms of how we might practice and how our practice and ideas and attitudes can be perceived. Deprivation of liberty. These are all part actually of the Mental Capacity Act here, but we need to be thinking about the application of restrictive practices. So care can be expensive for patients. You know, so I think that became very obvious to me in a kind of shocking way. Actually, I was in a different part of the world, and there was this hospital that had, you know, two entrances, one for the people who were unable to pay and one people for the elite. And you can't have kind of a biggest contrast than that. So we really need to make sure that people are not disadvantaged. And using data, I think actually there seems to be a lot of data around. Probably there is a bit less about use of data or how we can identify where the data lies. And even in the UK, all the time, I discover that there are new data sets that I didn't know anything about. And I can ask I can mine them for all sorts of different questions, because they can tell me how I might be able to deliver better services. So that can be, in fact, something that we need to harness in a much better way. So, for example, you might think, well, I've got this data. What can it tell me about who goes to hospital and has an intellectual disability? We published a paper a year or two ago, which is, and that was in PLOS Medicine, so it's available to everyone, and kind of without the paywall. And in that, we actually showed that even in the UK, with all the effort that has been made into annual health checks and all of that, still people with intellectual disabilities are not being identified as having an intellectual disability when they go to hospital. So you can see that it doesn't really matter. Problems and gaps are still there. And of course, linking data, from hospital, from GP practices, from social care as well, can help us to offer better support. Some references here. And thank you very much for your attention, and thank you so much for the platform today.
Thank you, Angela, for so lovely conference. Invitamos a todos a que sigan a Ángela en Twitter. Es muy
And
activa.
please follow Angela in Twitter. She's very active in her communications in Twitter. So hopefully you start following her. That's very important. So we are now going to introduce Megan right now. Her presentation is entitled Interventions to Support Individuals with Intellectual and Developmental Disabilities and their families in the United States. So, Megan, the floor is yours, and thank you so much for being with us. And once she's done, we'll take a few minutes for some Q&A.
Thank you. Thank you, Marcela. Thank you so much for your introduction, and thank you to Paulina for inviting me. I always like doing anything with you, and I feel like this presentation is well timed after Paulina and Angela, because Paulina's already introduced similar methodologies to test their interventions, which I've already, so I'll be able to lean on that. And Angela's already talked about service delivery systems and some of the complexities in them, which, as you've also mentioned, happens in the United States as well. So what we know is that when individuals with disabilities receive services, there are positive outcomes. And this means for school-age children, there's better educational progress. As people with disabilities age out of school systems, there's better post-secondary outcomes like employment and living in the community. But there are also positive outcomes for the family, including improved family quality of life. Is 21. So I do have a short video, because I always think it's nice to hear directly from a parent before I introduce kind of parent advocacy interventions. So you're going to hear from a parent who is in Massachusetts, and she is talking about kind of her advocacy journey and the importance of knowledge. Jay is 21 and Anand is 18. My wonderful, amazing younger son, Anand, has autism, but autism does not define him. My biggest concern is not only access of services, but knowing of one's rights and possibility. Parenting is hard in itself, and having a child with disability impacting his and everyone's life around him, it's even harder. I wish there was a manual to raise a kid and another manual for navigating the system for services. I wish I had known 14 years ago what I know today. Every day we learn something new from our kid and something new for our kid. Fighting for every little thing at school and system, it's very, very frustrating. And we shouldn't be spending our energy on that. We need to change that. Our kids need our patience, our energy, our knowledge. The better school system, which gives kids what they need, is needed.
We need a way to explain what should be done and how it should be done. A manual to explain the system, services, possibilities, what is available, on what can be done in a better way. We need some resources to explain the families who are new in this, who have no idea what is in it for them in future. I cannot turn the time back for my son, but I decided to help the other moms who are in the same situation. I share my knowledge. I bring moms together so they can share their concern, share the ideas, and be there for each other. I built the Moms Network for Indians moms so they can come together and build a bridge between two different cultures they share. I wish I could have done it earlier. I wish I could have done it in a better way.
I think it's just such a powerful video in so many ways. Hearing from a parent, we have over 100 videos from parents across the United States talking about their experiences with advocacy. I put the website at the bottom. The videos are in English and in Spanish if you wanted to see them. But I think it sets up this idea that advocacy matters and that families want support in advocating. So we hear that from families, but we also know this empirically. We conducted a study with 185 parents of transition-aged youth with autism in the United States. This was across 3 states, and we were looking to see if parent advocacy predicted the number of services that their child received. And what we found that parent advocacy activities were significantly and strongly related to receiving services. And this is even after controlling for variables related to the youth and variables related to the family. So even after controlling for whether or not the youth also had an intellectual disability, gender, social impairments, challenging behaviors, and characteristics related to the family like income, race, depressive symptoms, parent advocacy explained more than 10% extra variance in service access. So this tells us exactly what that parent just told us, that advocacy matters, and if parents advocate, their child is more likely to receive more services. Unfortunately, this story is not quite that simple. There are a lot of barriers to advocacy. And so I could spend the next, less than 20 minutes that I have talking about all these barriers that exist in terms of advocating for one's child. But on the same tone that Angela said, I don't want to be negative. So I'm going to move straight on to how do we mitigate those barriers to advocacy. So to that end, I want to talk about 2 interventions that we've developed. One focuses on school-age special education services, and the other one focuses on adult services. So we'll start on the school end, so we go in chronological order. And I like to show this slide because it kind of underscores some of the barriers that families experience when they try to advocate for services. So this is a picture of an IEP meeting. There are IEP meetings at least once every year, and they're the big annual meetings where the family and the school comes together to decide on the services the child's going to receive from the school and the placement the child's going to be in, the extent that they're going to be included, if at all, in the general education classroom. And they tend to be very stressful meetings for families. So what you see in this picture is there's a series of school professionals on one side of the table, like the gen ed teacher, the special ed teacher, the speech language pathologist, occupational therapist, and so on. And there's a parent and an advocate on the other side of the table. And one of the school professionals says, I'm not sure why Mr. Barth always feels compelled to bring an advocate to the IEP meeting. And at the bottom of the comic strip, it says outnumbered ? It can feel like this, whether it's intentional or not. If you come in as a parent and there's 10 people on the other side of the table and you're set up like in a you versus them situation, it can feel very disempowering for families to advocate for services in that kind of context. So to address that, over 10 years ago, we developed something called the Volunteer Advocacy Project. And the VAP is a 36-hour advocacy program, so not as long as Paulina's. That actually made me feel a lot better, but long. It's intensive. We've done it in all kinds of ways. We've done 6-hour sessions on Saturdays. We've done 12, 3-hour sessions or 2-hour sessions. It tends to be highly feasible. It's not exclusively for parents of kids with disabilities, although 60% of the people who go through the VAP are parents of kids with disabilities. The reason why it's not exclusively for parents is that the purpose of the VAP is not to train parents to help their own children. It's to train individuals to advocate for other families of kids with disabilities. So it's like a pay it forward model, which means that you don't have to advocate for your own child to be able to participate in it. Although most parents want to participate in it so they can learn how to advocate for their own child as well as other families. The content focuses on special education policy in the United States and non-adversarial advocacy skills. So we're not setting people up to wage war or to start litigation against the school. We're trying to get them to have advocacy skills that help them negotiate with the school district. It includes guest speakers, case studies, and some didactic instruction. So we've done a randomized control trial, which Paulina has already described to you very well, comparing the intervention and the control group. In this particular trial that you're seeing here, again, just like Paulina, it's amazing how things are consistent across countries. It's primarily moms. It's in this sample, 100% moms. They're the primary ones who are in the school advocating for services. Income-wise, it's relatively diverse, although it's pretty high income. Race-wise, it was primarily white. And type of gender, this is open, or type of disability, this is open to families or people of all types of disabilities. But you'll see that we have a heavy disproportionality in terms of families of kids with autism who are going through the training, which aligns with the literature in the United States. Families of kids with autism tend to advocate more and are more likely to have problems with the school district. So it's not really surprising that our sample would tilt in that way. What we saw between the intervention and the control group is that thankfully we saw significant increases for the intervention group and not the control group in terms of their knowledge of special education, their ability to advocate, so their advocacy skills, and their feelings of empowerment. Now, you may be wondering, that's great, but you said that the primary purpose of this is not just to help your own child, but to help other families. So we asked that. We interviewed families who worked with VAP advocates, and we said, what was the effect of working with a VAP advocate? And thankfully, we found that a lot of the families said there was a positive influence on their own child. Because they worked with an advocate, they were more likely to get services, their child had a better school experience, and the student demonstrated greater progress. This was what we were hoping to see. That was our hypothesis. What we didn't expect is that advocates also said that the VAP advocate impacted their family, which again kind of aligns with Paulina's intervention about caregivers, right? There is this bidirectional effect between if your child is doing well, you're probably doing well as a parent and vice versa. And so what we found is that the family said, I have better well-being, I have better partnerships with the school. One family said, I think the advocate actually lowered my own anxiety. So this is kind of an exciting thing that we weren't expecting, that the VAP advocate could actually influence family well-being. Now, we've replicated the VAP in about 16 states across the United States. So we're not quite halfway there across the country, but we're making progress. I want to highlight 2 of the states. We've done it in South Carolina with a community agency based there. That agency is primarily comprised of parents of kids with disabilities who replicated the VAP. And we have also done it in New York, and that agency serves Korean American families. So they actually translated the VAP into Korean and then delivered it to their families. And I think this is really important because we're trying to get away from the researcher being the one delivering the VAP. We want it to be done in the community. We want this to be something that the community feels like after a grant ends and we're no longer able to provide funding, that they can continue to sustain the VAP. And so this has been a great partnership for us and really kind of a big tenet as we think about developing the VAP and refining it. So what we saw in that study is that it was pretty feasible. At both sites, participants were either highly satisfied or satisfied with attending the VAP. What somebody said at the New York site, which is the site that served Korean American families, is this sense of community is the outcome that we really didn't expect. We thought that, oh, we learned this knowledge and we're going to use this somewhere. And I thought the participants are just going to go away with that, but they became a community. There's a possibility we can make the community grow and expand out of this. So again, kind of a nice finding. It's not a goal of the VAP to develop a disability community or insiderness, but it's also not surprising because the participants spend 36 hours together. So they get to know one another, especially in this case, they have some shared experiences of raising a child with a disability and being from the Korean culture. So we're very excited about where that could lead. In terms of quantitative findings, we also saw significant increases in knowledge after taking the VAP, empowerment, advocacy skills, insiderness, and grit. So I will move on to our adult disability services. I want to make sure we have enough time for questions at the end because I know people have already posted some in the chat. So school services are difficult to navigate, but they're much easier in comparison to adult disability services in the United States. In the United States, school services are housed within the school system. There's just one place to go to learn what the system is and how it works. There's one big policy that guides all special education services. You only really have to learn one law. Adult services are fragmented. They're in completely different silos. There are different policies that govern each of the different policies. They're underfunded, and because of the silos, they're very difficult to navigate. And that's why in the United States, when people talk about transitioning out of the school system, parents often characterize it as falling off a cliff, because it's like you're in this one place and everything is housed there, and then you leave there and you're kind of don't know where to go. So to address that, we developed something called Assist. This is a 24-hour advocacy program, so it's a little less time intensive than the VAP, although not by much. It's still quite a bit of time. It's focused on adult disability services, so you'll see that in the graphic here. Things like employment, special needs trust, person-centered thinking, secondary education, post-secondary education, vocational rehab services, independent living, technology. So it runs the gamut in terms of the type of service. This project is focused on parents of transition-aged youth with autism. We kind of bookend this at ages 16 to 26 for the youth with autism. So we've piloted this, and we've also conducted testing using a multi-site randomized control trial across 3 states in the United States. But I actually don't want to focus on Assist for the next few minutes. I want to focus on a little tiny aspect of it, and that's right here. So what you'll see is just like Paulina, just like the VAP, most of the participants are moms, but also most of them are white across these 3 states. We had a very, very small Latino population that completed the VAP. And this is problematic because we know that our Latino Spanish-speaking families face unique and exacerbated barriers in navigating adult disability services. And so let me give you an example. In the United States, one of our big services is called the Medicaid waiver. The Medicaid waiver provides housing and personal support workers and technology. It's kind of like winning the lottery in terms of adult services in the United States. Everyone wants a Medicaid waiver. And so in Tennessee, our Medicaid waiver is called Employment and Community First Choices. And if you go to their website, this is what you'll see. It's all in English. And at the bottom, you'll see there is a button that says translate, and you can translate it into Spanish, which is great. And then you'll see here that there's a spot where you can go and you can complete online the form to access Medicaid waiver services. So you click that link, and it takes you to the form completely in English. And there is no translation button to translate it into Spanish. There is no number to call. There is no one to talk to. There are no instructions. And so just at the most basic level, if you are a Spanish-speaking family, you cannot even apply for waiver services in the state of Tennessee in Spanish. So we developed something called Asistir, which is an adaptation of Assist for Latino Spanish-speaking families. And I want to be very clear that I had the privilege of working with Janeth Elmain Tovar, who's now at a California State University. She started this project as part of her dissertation, and she is the one who adapted all of the training into Asistir. She did that by working with over 20 Latino families, going through the curriculum, adapting it to make sure it was culturally responsive, pilot testing it, and then leading up to our big randomized control trial, which I'll share with you. So just like Assistir is 24 hours of training. There are 2-hour sessions per week. They were conducted over Zoom. All of the sessions are facilitated by a Latina mother of a child with autism, and it's offered entirely in Spanish. So families could be bilingual, but the training itself is offered in Spanish, and the materials are available in English and in Spanish. At the beginning of every training session, we have videos about each adult disability service. So in English, you will find information about these services across the country. In Spanish, you won't find much information about these services. And so I'm very excited that as a result of this project, we not only have research and, thankfully very positive findings, but also we have a product. We have 12 videos that are in Spanish about each of these adult disability services. This mom that you see here, she's Latina, she has a child with autism. She facilitates all of the videos. And for each video, we have a family story from a Latino family talking about their experience navigating that particular service. And all of these videos are about 10 to 15 minutes in length, so they're short, and they're all freely available online at that website. You can see them there in English too, but I feel like this is a huge contribution to practice and to families to be able to have this publicly available. So in terms of the randomized control trial, we had a lot of interest from 57 families, but ultimately randomized 48 of them, 24 to the intervention group and 24 to the control group. Pretty similar to what's been said. It's primarily moms, but very different than the VAP. Families who tended to have less formal education, families who tended to have less income were significantly more likely to be represented in the trial. And there were no significant differences between the intervention and the control group. In terms of proximal effects, I'm so excited because this is the first time I've shared this with anyone. But what we found is that the intervention group, you'll see here, versus the control group, after taking the intervention, demonstrated significant increases in their knowledge about adult disability services, their abilities to advocate, and their comfort level in advocating. And we measured this at baseline, we measured it right after taking a CCER, so after the 12 weeks, and then we measured it 3 months later, and you'll see that those effects either maintained or they increased 3 months later. So we're very excited that those effects seemed to stay there. We also looked at empowerment using the family empowerment scale, which has 3 subscales: empowerment within your own family, empowerment within the service delivery system, and empowerment within the community political environment. And we only saw significant increases within the community political environment. But what I will say for another study is that for family empowerment, we already see very high feelings of family empowerment among Latino families. There seems to be a ceiling effect, actually. And when we compare our assist families, who tended to be white, and our assisteer families on the family empowerment subscale, our assisteer families are actually much higher, significantly higher than our assist families. So we're excited about this finding. But what we're really excited about is that we then looked at the number of services they were getting. So we looked at number of services and unmet service needs. We wouldn't expect this necessarily to increase right after taking the intervention. We're really expecting it to increase at that 3-month follow-up. And we saw that for the number of services, our intervention group demonstrated significantly greater services 3 months after taking the intervention than the control group, which is what we were really, really hoping to see. So in conclusion, before we transition to questions, just a few takeaways, at least that I have from these research, is that knowledge and peer support is critical. All of these interventions are done in a cohort format where parents get to learn from other parents, and all of them are facilitated by a parent of a child with a disability. And I feel like that really contributes to their efficacy because that lived experience, that shared lived experience seems to really matter. To that end, all of the interventions are designed and facilitated by parents of kids with disabilities, and I think that helps increase their feasibility. All of the interventions are partnerships with community-based organizations that are staffed by parents of kids with disabilities, and I think that helps to make sure that our research is successful. And finally, regardless of socioeconomic background, educational background, language, we saw that parents want to advocate, and parents are advocating when you give them the supports and you help mitigate barriers. And not only are these parents advocating for their own children because of that interest, but also they're advocating for other families for free. And they're often advocating at a systems level. They're actually trying to change things, not just for their own child, but for all children with disabilities, which is a huge testament to the resilience of families. So I will stop there and turn it over to, I think, Marcela for questions. Thank you.
Muchas gracias, Megan, por tu
Thank you.
presentación.
Thank you, Megan, for your presentation. We have some 10 minutes that were considered for some Q&A. And we received some questions. I've organized them and I will ask them in the order of the presentation. So for Paulina, the question is whether there was any difference, gender difference in the teenage project. And they also ask what happens with comorbidities. If there were other comorbidities among the parents, they were also asking whether the parents had other comorbidities. And please tell us, Paulina. Well, regarding gender-based differences, we did not do that kind of analysis in the project with the teenagers. And I will, more than the answer itself, let me tell you something that has happened in our projects and the projects we're working with people with intellectual disabilities, teenagers and adults, is that we have a very low engagement of women. Because in that project, we realized we were surprised. We conducted a different project with an intervention to build leaders in intellectual disability in order to work with teenagers and young adults with intellectual disabilities and their caregivers and families and professionals associated with those groups. And in that, we saw the same. It was very difficult for women with intellectual disabilities to participate. And something that we've been exploring with the families and with women we have worked with is the question why. And it seems there's overprotection from the families. It is very hard for them, especially in teenage girls, to let them participate in activities with men, in activities in which the parents are not involved beyond the school time. So there's significant overprotection. Another time, we will be able to discuss the work that Constanza Lopez is doing. She is our postdoc researcher now at MICARE. She's specifically focusing on the work with women, autonomy, sexual and reproductive independence, because we know there's something relevant in that, and she is exploring that. And as to comorbidities, of course, all projects, Angela mentioned that when we work with people with intellectual disabilities, many times we see that they may be in the autism spectrum or they may have attention deficit in the Baby Mikade project because of the characteristics of having a baby in the autism spectrum in terms of developmental evolution. There was an exclusion criterion. I think these are very, very young babies. So many times it happens that at those ages, babies between 12 and 36 months, you are able to identify autism around 24 to 36 months, up to 5 years in Chile, more than that even. So what happened in a couple of cases is that during the intervention, we realized that maybe we didn't identify that, but maybe there was a comorbidity involved, and those children were part of the intervention, but they were not a part of the analysis because we wanted to keep the data clean, and the same thing applied to teenagers. But we realize, as Angela said, that there's a condition that overshadows the other. There needs to be a formal identification process that in the interactions with them we realize, and we exclude them not because we believe the intervention is not effective, but it is a research methodological aspect. Possibly, it's a population that will require different types of support. Okay, thank you, Paulina. I'd like to invite everyone who's connected from the different institutions to help us in Chile to push for the engagement of women. It's very hard for women with intellectual disability from a certain age, around 13 or 14 years of age, to get out of their homes and their families and to be linked to programs in which families many times uh, believe there may be some risks. There's lots of fear regarding sexual harassment and abuse for teenage girls and young female adults. There's a question for Angela. Angela is available. It's available in the chat if you want to see it in English. I will ask it in Spanish. They say that you said that sometimes one needs to respond to public policy and then to do the research to provide evidence. Sometimes we come up with policy first and then we see. The question is whether you could elaborate a little bit more on this idea and what has been your experience dealing with the promotion of public policy that is evidence-based with also the work involving the academia, linking with politics in order to aid people with intellectual disabilities.
Thank you for the question. So there are some specific examples that I can think of. Where, for instance, the situation with the deaths, the national mortality audit. So in order for this to become, it became, first of all, an idea that, we must do something. There were some case reports that things are not, there are people with learning disabilities, for example, who die in hospital. So there was some advocacy and lobbying to say something must change. There wasn't really a lot of evidence to say that there should be a national program, but there was a discussion that we must have a national program. And then there is the research, which actually says, yes, we looked at the records of 300 people with intellectual disabilities who died in hospital. And actually we can say that these were the reasons, these were all potentially treatable conditions, but nobody thought that they were happening in the person that actually had the condition. So we really need to look at this to see what we can do. So then, whilst there is an idea about an initiative and a policy, it was also the 300 cases and records of those cases, or the death certificates and so on, and investigation around the death of those people who actually then said, oh no, the government does have to make this a mandatory statement. The same thing goes with the health checks. The health checks became an initiative. The practices were incentivized, but then in order for the practices to opt in, we had to provide the evidence. So we said that, yes, if you actually do the health checks, you're going to increase the number of referrals to other, to hospital departments and so on, because you discover things that you would not have seen had you not done that. So, there is, first of all, there is the response to something that becomes a kind of national disgrace. This is happening, we've got to do something about it. And then you provide the evidence. Now, the idea is that, of course, you have the evidence, but sometimes you don't. You just have bits of information, that almost instinctively makes sense. There is quite a lot of pressure. So the government has to do something, and then you provide the evidence. So really, this is actually quite permeable. Like, you do something and there is a response, sometimes a pushback, sometimes, yes, we will do this, etc. It takes time, but then you kind of work almost in parallel. So that's what I meant.
Muy interesante, me alegra mucho saber que en Inglaterra también.
Interesting. It's great to see that in the UK there's also some tension between academia, evidence, and public policy making, because it's one of the big challenges in Latin America. We also experience the fact that we need to uh, uh, inform policymakers the idea that they need to look at the evidence, hopefully, before advancing in policymaking. Thank you, Angela. For sure, this topic would actually be worth for an entire conference. And in closing, there's a question for Megan. It says, Megan, they love your work. They ask you if you could elaborate a little bit more uh, if the effects have been measured in adults or with intellectual disabilities, and if you could give your opinion and experience when dealing with this transition period after the school years, which is an issue that we are experiencing in Latin America.
Yeah, that's a great question. I'm glad you like that project because I'm so proud of it. Um, in that particular project, we measured service access in a bunch of different ways for the autistic adults. Did you get access to the service? If you didn't get access to the service, why? Like, what are the barriers? Because there's a big difference in if the barrier is you don't have knowledge or you don't feel comfortable advocating, then an advocacy intervention could matter. But if the barrier is you know what the service is, you know what you need to do, you've tried to advocate, but the funding isn't there for the service to be provided, that's a systems issue, right? And so our intervention wouldn't be targeting the right thing. We would have to change it. So we asked questions related to that and unmet service needs. We asked, I think we used the social responsiveness scale for the autistic youth. That was the only other measure looking at the youth. But in this area of research, which I think is just services research, not specific to the age span, it it becomes harder and harder to measure those distal outcomes because what we're looking for is you're doing the intervention and then we're looking for the mechanisms. So we're trying to increase advocacy, knowledge, empowerment. So that has to happen. And then we're looking for an impact on service access. And it takes a while to access services. And then once you get the service, we should see an effect on kind of youth outcomes, right? Employment, post-secondary education, adaptive functioning, whatever. And for this project, we only had 2 years. So we didn't measure many outcomes, but I'm hoping we can scale it up given the promise of it to really look at whether or not services matter, which I feel like they will.
Bueno, muy bien, muchas gracias, Megan. Hay muchos
Thank
desafíos.
you, Megan. There are so many challenges ahead, but we have a job. At least we have things to do. We have things to work on. We're right on time. So we'd like to thank everyone who attended, who were joining us today during this webinar. Please remember that there's going to be a recording in the YouTube channel of Mikade, so you can watch it and also recommend it, socialize it with other people. And we'd like to especially thank Angela and Paulina, who were the drivers behind this activity. Thank you so much for all the work prior to get the funding and to make this a reality. We're really happy because we also have this voice from 3 regions in the world that believe this is the right way of doing things in terms of impact out for people with intellectual disabilities and developmental disabilities. You're please. You're kindly invited to visit www.micade.cl. Micade has one layer in English, but also thinking of the community we serve, there's also an easy read layer that is available to facilitate communication. Very soon, we'll be launching a series of comics, cartoons, through which we hope to communicate in very simple language the results of some of the research that we have published. So we need to send a message to editors of the different journals so we can make some more progress in ways of communicating a bit more responsible and responsive to the community. Your like is our salary, so please don't forget to share and to interact with our content in your social networks. Thank you all to everyone who attended. Uh, and a special thanks uh, uh, to Angela and Megan, who have been kind enough to be here with us and supporting us. May you all have a great day and great evening, I guess, for Angela.
Gracias.
Thank you very much. We'll talk. Bye.
Bye.